Good afternoon, everybody, and welcome to our iGeriCare.ca second live event coming to you from McMaster University. I'm here with Dr. Richard Sztramko, geriatrician and co-founder of iGeriCare, and I'm Dr. Anthony Levinson, a psychiatrist here at McMaster University and Hamilton Health Sciences. So a few things, housekeeping issues about today's live event. One, during some of our tests, we did have the occasional technical difficulty. If the live stream of the event, for whatever reason, goes down, just be reassured that we will keep talking and recording our responses to questions, and that recording will be made available through iGeriCare.ca/events, through our Facebook channel, and through YouTube. So just like in real life, when people stop listening to me, I will keep talking, only this time it'll be recorded. Things about live event 1, where we covered off some important issues for how to be an effective caregiver. The recording of that live event is available through those same channels that I just mentioned. And we also had an opportunity to go back and answer some of the other viewer questions that came in, and a recording of that Q&A is also available. Today, we will be talking about what I would say is maybe an under-recognized, underappreciated symptom of dementia, which is apathy. And we'll also be talking about depression in dementia. So please send us in your questions. If you're watching on Facebook, you can use the Facebook commenting tool to send through your live questions. And we've also been fortunate to receive questions during the break between our first live event, so we'll try to answer some of those as well. Today we are, based on your feedback and people who responded to the survey, we have increased the length of today's live event to 45 minutes. And if we have unanswered questions at the end of that time, we'll try to do the same thing and record a few more Q&A questions that come through. So today, let me ask you, Dr. Sztramko, can you talk a little bit about what it means when we say that someone with dementia has apathy, and maybe say a bit about the impact of that on the patient and especially on the caregiver?
Sure. First of all, apathy is a very common symptom that occurs in people that have dementia. It can occur in up to 50% of people that have dementia, so it's very common. And it's displaying a lack of goal-directed behavior or volitional behavior where people want to get up and actually engage with the world around them. They may show a little bit less emotion or concern or interest in the people around them and the world around them. And people can appear very withdrawn. So before they had any kind of cognitive impairment, they may be getting up, going around the house, doing their laundry, going out and playing sporting events, being involved in hobbies, being involved in social events, and after they get cognitive impairment and experience dementia, they show lack of interest in those activities. They may become more withdrawn and sit around the house for large periods of time. Occasionally people may be able to watch TV for 6 or 7 hours a day, and this wasn't common for them before the onset of the dementia occurred. So people can see quite a significant change in their loved ones, and when that behavior changes, it's quite concerning to them. People may experience a lot of guilt related to the fact that their loved one is sitting around the house, and caregivers may experience a lot of anxiety around the apathy because they don't feel as though they're doing a good enough job, right? The caregiver wants to get their loved one up, get them moving around, get them out and socializing, and often they'll ask us as a clinician, what can I do to get them out and about? What can I do to get them back interested in these activities that they used to be in? So it's a very concerning symptom, and it's a very common symptom.
So I guess just a bit of a recap. What the caregiver or the family might see is that the loved one with dementia does not seem to be doing as many activities. They may notice that they're sitting around a lot more and display a lack of interest in things that they used to be interested in. And I think what we often see is high levels of frustration from the caregiver. One that they are trying to get somebody to do things, or maybe some of the activities that they used to do together as a couple or as a family, if it's a younger caregiver, and then a sense of guilt. Why am I'm not doing a good enough job of kind of getting the person active. So, can you say a little bit, because I think sometimes when people see their family member not doing things, not taking an interest, they may think that the person has depression. And can you maybe describe a little bit some of the differences that you see between apathy and depression?
Certainly. So depression usually has other things associated with it. So it's not just a lack of interest. There's often sad feelings or feelings of being down. And we all experience sadness in our lives, especially in response to certain events, so the death of a loved one, a set of stressful circumstances that come into our lives. But if you're feeling persistently sad or down, most days, for most of the day, for a 2-week period, that's considered to be depression with a few other associated symptoms. So lack of engagement in pleasurable activities or activities that you previously found pleasurable is another symptom. And then other things, people can be sleeping too much or too little compared to what they were before they were depressed. They may complain of difficulties concentrating during their day-to-day activities. People, when they're observing people that have depression, so caregivers may say that they appear more agitated, or that their movements are slowing down, or their thoughts are slowing down. It's called psychomotor agitation or retardation. And then there could be an increase in sense of guilty feelings. Occasionally, people may also be concerned of having increased thoughts of death or ruminating on death, and even express interest in killing themselves, so suicidal thoughts. These symptoms are the standard symptoms for depression, and I hope I'm doing a good enough job with these symptoms, talking to a psychiatrist who's an expert, so feel free to jump in. But the symptoms can change just with age. So people that are older that get depression may have some symptoms or may experience depression slightly different. They may complain of increasing pain, so non-specific abdominal stomach pains or knee pains. They may just talk passively about death, about how it might be better if they weren't around at all. And you might observe these people as well start trying to get rid of their possessions. And occasionally, people with depression, when they're older, may hear voices that aren't there, or see people or animals that aren't there. And so those are hallucinations or even delusions sometimes. So there can be those components of it. So
I think sometimes it can be challenging to tease apart apathy from depression, but I think you've hit the nail on the head that what we see for the most part with apathy is just the flatness. And in fact, the person is not necessarily sad or ruminating about death. They are just not, they just don't feel like spontaneously doing activities or going out. They're actually sometimes relatively content to just sit in front of the TV for hours, or even just sit sometimes and stare into space. Whereas typically the person with depression is articulating some of these other thoughts, the sadness or thoughts about death and dying. So what do we know about the cause or causes of apathy or depression?
Sure. Apathy is really related to the frontal lobes in terms of brain function. So as you can see here, this is the front part of the brain called the frontal lobe. This is the temporal lobe. The back part of the brain is called the occipital lobe, and this other area here is called the parietal lobe. I don't want to get too technical, but on the inside of this part of the brain is something called the cingulate cortex, or the anterior cingulate cortex. And so when that area is damaged, it can be damaged from something like a stroke or from toxic proteins, such as we find in dementia, if that part of the brain is damaged, you can see that we observe people become apathetic. So, for instance, people that have frontotemporal dementia really have early onset and severe apathy that's noticeable right from the onset. And you can contrast that to somebody that has Alzheimer's disease, which generally will have the short-term memory deficits, forgetting what's happened in the morning, and things like that. So whether you have toxic protein-related damage or blood vessel damage in that area, you'll find people become very apathetic. And even then, there are more severe forms of apathy as it progresses with damage to that area of the brain called mutism, where people won't respond to anything that you say to them and they stop talking. So it's a very important area of the brain. Now, we don't know 100% in all kinds of dementia what causes it. The brain is a complex organ. So that part of the brain is connected to various other parts of the brain, including all other parts of the frontal lobes. And so, it could be generalized damage in that sense that causes apathy. But I think it's interesting to know that there are very specific parts of the brain which are tied to your motivation and being involved in the world around you.
And just to echo that, a lot of complexity and a lot of different signs, symptoms, characteristics, functions that are all in that front part of the brain, which is quite large and has connections to many other parts of the brain. And we do see apathy often, though, in people who, for various reasons, have had some kind of damage to those front parts. In terms of causes of depression, I'm not going to go into too much detail because I want us to get to some of the questions, but there's still not a very in-depth understanding of the very specific causes of depression. There are changes in chemicals in the brain and these circuits. We talk about neurotransmitters, which are the chemical signals that travel from one nerve cell in the brain to another. This kind of simplified idea, when you multiply it by the millions of brain cells, our understanding is still pretty primitive. But we know that some of the treatments that are effective do change the balance of these neurotransmitters or nerve cell chemicals, and that's one approach to the treatment of depression. With respect to treatments for apathy, what have you got for us on that front?
It's a really challenging symptom to treat. There aren't any great medical treatments, so there's no pill that you can take. There's been multiple drugs that have been trialed, but none with any great success in dementia. So you're also left with trying to change the environment or trying your best as a caregiver to get somebody out. There's been some studies in nursing homes or long-term care facilities which show that by changing the environment and making the environment more engaging, you can sometimes help, but that's very limited evidence. Most of the evidence suggests that it's not a particularly modifiable symptom to have. So a lot of times it's the caregiver who's experiencing significant amounts of distress about the person not getting out. And when they start understanding that it's not the person's choice, it's not the person with dementia's choice to be that way, and that oftentimes, and you remove the possibility of them being depressed, then you can give them permission to actually sit there for periods of time without feeling the stress and need to get them up and moving. And that can be liberating for a lot of caregivers to understand that it's not their choice. These are actual people that are having damaged parts of their brain which are resulting in them not wanting to get up and do things. So it's always reasonable to try your best, but at some point you have to kind of take care of yourself and limit the feelings of guilt associated with the fact that they have an illness and that it's not their choice to get up and it's not your choice, And oftentimes, there's nothing you can do to make it better.
I think that harkens back to one of the reasons why we've put together the iGeriCare.ca resource and this lesson in particular on apathy and depression, particularly with respect to apathy. Knowledge may help with acceptance for the caregiver and patience, because I think sometimes that it's that anxiety and that frustration that is really challenging for caregivers. So
I think you're right, and we talk about this particular symptom as one of those big moments in the clinic where when a caregiver does understand and accept it, light goes on, and suddenly they feel that their burden is lessened, as they don't feel quite so responsible for every aspect of that person's care of what they're doing every second of the day.
I'm going to defer, talking about treatments for depression, because I think it'll probably come up in some of the questions, and I really want to have a chance to thank the people who make this possible. So funding for these live events and the recording and archiving of them is provided by CABI, the Canadian Centre for Aging and Brain Health Innovation, powered by Baycrest. We've had additional funding for the production of the e-learning and from the Jarrah Centre at Hamilton Health Sciences, McMaster University, the Hamilton Health Sciences Foundation, the Alzheimer'S Society of Hamilton Halton, and none of this would also be possible without our crew at the Division of E-Learning Innovation here at McMaster. So we're going to move now to talking about any questions that you have and answering those questions. I just want to preface this, that this is a free educational service, just like our iGeriCare.ca site. We are hoping to provide knowledge and education about various aspects of dementia and to help with the caregiver challenges and roles, but we're not giving direct medical advice. So you may send in specific questions, and we can't really take the role of being your consultant physician. So we'll try and answer questions as best we can with some key educational points, but just be aware that this can't constitute medical advice, and you should follow up with your healthcare team around specific issues. There is also a survey that's pinned at the top of the Facebook comments. We're really looking for your input on topics to cover in future live events, the format, does it work for you? As a response to the feedback, we prioritize certain topics, and we've also increased the length of this live event. So at this point, I would love to go to some of the viewer questions that are coming in. So here's an interesting question. This person is involved in the support of people living with intellectual disabilities, and there's a person that they support who has Down syndrome, or trisomy 21, which is a genetic disorder that also predisposes somebody to Alzheimer's disease. Can you say a little bit about, they're looking for are there any specific things that might be helpful for them as they're supporting this person with Down syndrome and an early onset of dementia?
Definitely a challenging question. I think one thing is, the definition of dementia does, as part of its requirement, does require that the person have a decline in their cognitive functioning, so their memory and thinking abilities from a previous baseline, which helps to differentiate it from something where you have either a learning disability or an intellectual disability, such as in Down syndrome. So when people are experiencing dementia, when they have Down syndrome, you'd expect a further decline from their baseline, noting that things have worsening and their degree of function would become further impaired compared to their baseline intellectual disabilities from their Down syndrome. Do you have anything you'd like to add? Or?
Yeah, so in some of my clinical experience with working with patients with intellectual disabilities, particularly Down syndrome. In addition to the dementia, people with Down syndrome are often more prone to certain types of anxiety disorders and obsessive compulsive disorder, or OCD. So sometimes what one can see is when there are more cognitive impairments, you can see some worsening of some of the other mental health challenges that occur. So sometimes people will become a bit more anxious. They may repeat themselves more because their memory problems are worsening, and that may also feed in somewhat to some of the OCD symptoms, where they one of the symptoms that we sometimes see with patients with Down syndrome, but also patients with the damage to the frontal lobes, is that repetition of particular phrases or ideas. We call it perseveration. And well, we think of it, it's a good characteristic to persevere. If somebody is persevering too much and they are perseverating and repeating the same ideas, they can become very anxious and overwhelmed by thinking about the concept. And it's one of the things that I think that is a challenge for people supporting people with perseveration, which we often see in Down syndrome. So I would say, in addition to some of the strategies generally in terms of helping with dementia and the environmental supports, look to make sure that anxiety symptoms are as well managed as they can be on the lookout for depression. And I would say also just be mindful of the other medical complications that can occur in Down syndrome, because there's a range of other medical issues. So it's always important to follow up and make sure that there aren't medical issues that are contributing to the cognitive issues or depression. So,
great.
So we have some other questions coming in. Can dementia be slowed down if there's, the question was worded, if somebody's on the verge of it? So I guess there's, I'm extrapolating a little bit from the question, but let's say there are some evidence of cognitive impairments, not fully dementia, but can it be slowed down at all, I guess is the question.
Yeah, I think that's a great question. The first step always is figuring out whether there's any reversible component to the cognitive impairment or memory and thinking problems that the person is experiencing, because certainly, you know, if they had elevated levels of, let's say, calcium in their blood and you reverse that, then the cognitive impairment may improve. Or they're having some sort of thyroid problem where their thyroid hormone levels in their blood are either too high or too low. Those things could be reversed. And what you're looking at in that person and seeing with respect to their memory and thinking is related to thyroid hormone levels, then you can fix that problem, and yes, it can be slowed or reversed completely. If somebody has a toxic protein in their brain that's causing problems, the best that you can hope to do is mask or delay symptoms. Oftentimes when we see people in clinic, though, we don't know for sure 100% whether a toxic protein is causing it. So if we go through and we find that there's nothing reversible that we can see, then we do counsel people on various brain health activities, which can be seen in our iGeriCare lessons. You know, how to keep your brain healthy, and those things that we counsel people on that seem to have some impact on slowing cognitive decline are, you know, eating healthy. So for example, partaking in a Mediterranean diet or something similar to that, maintaining your cognitive activity, so staying engaged with the world around you and partaking in you know, whether it's crossword puzzles or Sudoku or reading books or things like that. Exercising, so you know, staying very active, and taking care of your general health. So trying to keep your blood pressure well controlled if it's abnormal. Trying to keep your blood cholesterol levels controlled, and if you have conditions like, you know, diabetes, making sure your blood sugar is controlled, to make sure that the blood vessels that lead to your brain and keep it healthy are as healthy as they can be. So it's more of a global approach, and
Yeah, great answer.
Yeah.
Make sure that this is actually dementia. Get the diagnosis right. Make sure that there's nothing specific that can be treated, a particular medical disorder or depression, and then some of the healthy lifestyle things. Really, our first 3 lessons on iGeriCare kind of address a variety of those things. So, another very interesting, complex question. What's the best way to address, this is a caregiver whose parent has been diagnosed with both Alzheimer's and Lewy body dementia, and has what's described here as becomes obsessed with one particular thing. So for example, with food, there's either too much food or too little food. And I would say this overlaps a little bit with what I was talking about in terms of either perseveration, where somebody may get a particular, almost like an obsession or a compulsion. They get an idea in their head, and then they may dwell on it and ruminate on it, and it can be a real challenge or a frustration for the caregiver. Any thoughts about this scenario?
Yeah, it's always challenging in that moment where they are focused on one thing. And so a common technique that we like to instruct people to use is that of distraction. It can be hard if they are obsessed, but instead of telling them not to be obsessed with the food or talking to them about the food itself, which is what they're obsessed with at that time, try and distract them to be interested in something else. So, would you like a cup of tea? Or if they're interested in football or some sort of programming on the television, say, oh, your favorite show is on, or, talk about what's happening outside right at this moment. And sometimes you can distract them away from being obsessed around that particular topic. It's still a challenge. It doesn't work 100% of the time, and none of these strategies are foolproof. So, you'll have to try a few things.
Yeah, I was going to say sometimes it's a question of trial and error, and having a consistent approach amongst different caregivers, whether it's a spouse or a family member. I feel like non-pharmacological or like non-drug treatments, using some of these behavioral tricks of the trade. If somebody in the family does come up with whether it's a particular food or a script that seems to work, it's like, hey, I tried this with mom and for whatever reason it worked, and then everybody can kind of be on the same page to use that strategy. There, in the setting of severe, say, obsessive compulsive disorder, severe anxiety, there are, other medication strategies with what are sometimes called anti-obsessionals. They're typically antidepressant medications that are also used for the treatment, but it may not be as effective in the setting where it's more of what we talked about with the damage to the front parts of the brain that are leading to some of the repetition or perseveration. So I feel like pharmacologic or drug treatments are going to be less helpful in this scenario and may run into more side effects. So I would agree with you about trying to, keep trying, try not to get too frustrated as the caregiver, and keep trying different behavioral strategies like distraction, if those can be helpful.
And I think, we mentioned being in contact with the Alzheimer's Society through FirstLink, getting access to occupational therapists as well. They can provide you with certain games that you might be able to play, sorting puzzle pieces or sorting colored pieces of paper, depending on the degree of cognitive impairment, so that instead of being distracted instead of being obsessed with food, they may get obsessed with something else which is less intrusive to their day-to-day activities. And so I'm kind of a global expert, and you're a global expert in diagnosis, treatment, and management. Sometimes for the non-drug-related treatments, the occupational therapists can be the best people. Like, that's their profession, is understanding how people can function best in their home. So we will get involved with occupational therapists quite frequently.
If you are fortunate enough to live in a region where you have access to some of those really skilled allied health workers, then occasionally they will have occupational therapists or behavioral therapists that can help provide advice around strategies. So worth checking in with your healthcare team to find out if those resources are available in your community. So we have another question that this is, how can we comfort or help a parent who is not only depressed but is also very anxious? They seem afraid to step into the shower, distrustful of relatives coming into the house when the relatives want to help out. So any suggestions around some of these anxiety symptoms in addition to depression that seem to be interfering with day-to-day function and independence and even interfering with allowing other caregivers to come in to help?
Yes. I think when symptoms become that severe, where they're truly impairing somebody's ability to even get in the shower, we consider pharmacologic or drug-related treatments at that point in time. Oftentimes when people are anxious and have memory and thinking difficulties, it's really hard to know where one stops and one ends. The anxiety will make the cognitive impairment worse. If they had cognitive impairment, that will make the anxiety worse. So frequently we'll have a set of steps that we go to with respect to treatments, and one of those would be a cholinesterase inhibitor to try and help with their memory and thinking problems. But as a side effect, it can also improve to a minor degree their depressive or anxiety symptoms. And I think from this point here, or this person's experience, it's also very important to note that often these symptoms occur all together. And that can be a challenge for us as well. Somebody can have a bit of apathy and be anxious and be depressed. So we just have to kind of start building on a foundation, and I'd usually start with the cholinesterase inhibitor. Aricept is the commonly used cholinesterase inhibitor, and start building up on a foundation from there to make sure that the cognitive side of things is treated. And if they're able to tolerate that and the anxiety and depression is still severe, we might consider an antidepressant at that point in time to help things out, and certainly getting our psychiatry colleagues involved.
I would say, very important to listen to the patient and understand in as much detail as possible, if they're able to express themselves, each of those particular contexts, because they could be different. So the anxiety about stepping into the shower may also relate to mobility issues, and so it may be a real world issue in terms of unsteadiness, and there may in fact be some physical strategies, whether it's grab bars or switching from showering to say more of a sponge bath or something like that. So just clarifying and trying to understand as best you can, listen to the patient. The distrust of relatives, is it related to not thinking they're relatives? Is there what we might call a delusion? And some of those can sound quite unusual. Like, I don't think they're my relatives. I think somebody's replaced them and looks like them. So understanding whether there are delusions. It's often the case that anxiety symptoms can be a manifestation of depression. So ensuring that the depression is well treated may in fact help with the anxiety and some of the other symptoms. So there's no one easy approach. Listen carefully, see if you can understand and address some of the symptoms, and then if it looks, try to treat as many of the things with non-medication strategies as much as possible. In cases where everything's been tried and those non-medication strategies are not working well enough and the person is still really distressed, then talk with your doctor or a specialist, if you have access to a geriatrician or a psychiatrist, about whether there is a role for medication management of some of those symptoms.
Definitely. And I think we deal with that in our lessons on managing behaviors. It's very important to be specific about what symptoms you're addressing at what times, and coming up with a log and seeing what the antecedent or prior behaviors are before they actually are experiencing the anxiety. So those are all great points.
So we have another question. Could anxiety be the initial presentation or primary presentation of dementia, and how common is that?
Yeah, I think it's a great question. Anxiety is a presenting complaint of dementia in isolation would be very rare. People that have anxiety may experience some minor cognitive impairment, difficulties with thought blocking or not being able to process things quite as quickly. But if you're seeing anxiety related to damage to the brain, then you would expect to see concomitant cognitive impairment at the same time. So it's not something that we commonly see. However, depression, I'd say, would be a much more common presenting complaint that can also be associated with memory and thinking difficulties. And I think as we've addressed in our lessons as well, sometimes it's difficult to tell, is this depression, is this dementia related to depression or not? And oftentimes we're left treating the depression to see if the memory and thinking problems improve. And if they improve, then we feel more likely that it was related to the depression itself.
Yeah, I would say, so very unusual that anxiety, in the absence of other symptoms like memory problems or language problems, would be the presenting symptom of dementia. I would agree with you. It's not that uncommon that we will see somebody have a depression at the outset, and what we often see is it's somebody who is having some cognitive impairments, and they have awareness that they are having problems with memory or language, and that may lead to a depression, but it's sort of the earliest symptoms, and much less common that we would see anxiety alone. Here's another question. Would treatment of anxiety or depression with antidepressants, for example, they name SSRIs, which are a particular class of antidepressants that are often used to treat depression and anxiety, would they be effective in people with dementia in terms of reducing or suppressing symptoms? And I guess they're commenting that they are saying, why don't we see any improvement? So I'm thinking that their family member or the person that they're a care partner for has been started on antidepressants for depression, anxiety, but they may not be seeing improvements.
Yeah, and we were talking about this just earlier today in terms of the scientific evidence for this, and it doesn't appear that the scientific evidence shows a large benefit for treating people with dementia and improving their depression symptoms. Although it's not completely clear, I've certainly treated people with SSRIs that have dementia and depression, and they've improved. So it's usually used as a last resort. We talked about using the non-pharmacologic strategies to try and improve somebody's sense of well-being, and then just being realistic with the caregivers and with the patients on what the benefits of treatment might be, as well as being very clear with the side effects or potential side effects that somebody may experience. So it doesn't work for everybody, and I think something to remember too is that we're just changing the levels of the chemicals in the brain, and if the actual cells in the brain are dying, sometimes there's not much to be done because those chemicals act on the cells that are already dead. So for some people it can be very effective. For other people you may not get any benefit and may just get side effects. Always try non-medical approaches first, and then if all of those things have failed, or generally if the symptoms are so severe that they're really causing an impairment in quality of life, then we can try some medical therapy.
The one treatment that we did not discuss in the lesson is for people with severe depression who are not responding to non-drug treatment strategies, who are not responding to even medication strategies like SSRIs. One of the other effective treatments that can be life-saving in the setting of very severe depression is what we call Electro-Convulsive Therapy, or ECT. So again, there would be other first line or treatments that you would try first. But for somebody whose depression is life-threatening, they're not eating, they're not drinking, they're essentially not able to survive without treatment, ECT can be a very effective treatment for severe depression, even in the setting of dementia. But it does look like there's not great science. Antidepressant medicines may be more effective than placebo or sugar pill, but they're probably not as effective in dementia than they are in people who do not have dementia. So here's a question that I think is more something that we can clarify educationally. So the question was phrased, can dementia lead to Alzheimer's? And I think this is a good opportunity to express some of the things that we cover in lesson 1 around the different types of dementia. Do you want to speak a little bit to clarifying this?
So dementia itself is an umbrella term, and what that means is that somebody has a progressive disorder or illness where they're experiencing memory and thinking problems, sometimes visual and spatial problems, sometimes language problems. And they get worse over time. So for instance, somebody can't remember what they did yesterday, or they can't remember what they did in the morning. They're losing their keys, they're repeating conversations, they're repeating stories. And so that impacts their ability to function independently day to day. And when that happens, and it's not related to any reversible cause, and it's not related to depression, then we say that that's a dementia. I don't know if you want to pull up the board here as well. The dementia disorders that we're talking about that are chronic and progressive usually happen as a result of one of two things. One are these toxic proteins here. And the toxic proteins, we're not sure why they come about. A lot of times the proteins themselves occur normally in the brain, but they start getting misfolded and misshapen. And when that happens, they can actually cause damage to all of the nerve cells in the brain, and that causes the brain to stop functioning. Slightly differently is when you have damaged blood vessels in the brain that deliver oxygen that allow the cells in the brain to function. If you have damage from either a stroke or slow degeneration or problems with those blood vessels, you also impair the brain's ability to function. So dementia cannot lead to Alzheimer's, but Alzheimer's can cause a dementia.
And it would be the most common type of dementia. So I think that's why sometimes people use the terms interchangeably. They talk about Alzheimer's or dementia, but in truth there are several other causes of dementia, though Alzheimer's is thought to be the most common. And sometimes you can have more than one type. So we would often see patients who may have a mix of both Alzheimer's and vascular dementia, for example.
I think it's a great question to be addressed in lesson 3, the different types of dementia. So, have a look at that as well.
One final question, because we're sort of almost at the 45-minute mark. Does treatment with cholinesterase inhibitors, those are those cognitive enhancer medications that you referred to earlier, does treatment with cholinesterase inhibitors for people with early onset dementia mean that you might increase the duration of their suffering from anxiety or mood symptoms?
Yeah, these are great questions. Cholinesterase inhibitors, again, just boost the levels of a chemical in the brain called acetylcholine. And the reason we think they help people with dementia is that, in particular in Alzheimer's disease, people have low levels of this chemical called acetylcholine. So if they have lower levels than normal and we boost them up to within normal levels, then we can improve a few things. And one of those things is some thinking capacity. Sometimes people will experience less depression and anxiety. If we observe them and see how they function day to day, maybe they can function a little bit better. So they kind of help in a general sense. The problem, though, with the dementia as we just saw, is that the proteins that are toxic and damaging the blood vessels are not treated by cholinesterase inhibitors. So cholinesterase inhibitors are helpful to alleviate somebody's symptoms or improve their thinking capacity to a mild degree, but they don't impact the course of the illness, and they don't prolong somebody's life. So because they won't prolong somebody's life, they certainly will not make suffering longer or worse. And in fact, because they can treat to a mild degree some people's depression or anxiety in the context of dementia, might actually improve their symptoms and decrease their suffering.
So thanks. That's really all the time we have for today to stay in with respect to our 45-minute allotment. Any questions that we didn't get a chance to address, we'll try to answer some of them on our Facebook page. Please take a moment to fill out the brief survey that's linked in the comment section. That will help to inform our future events. And just a reminder that our next live event will be November 7th at 1 p.m. We did get feedback that suggested this was a pretty good time. We did the first one in 30 minutes, this one 45, so give us your thoughts in the survey about that. Also like to take a moment to thank our sponsors again, especially CABI, the Center for Aging Brain Health Innovation at Baycrest, McMaster University, Hamilton Health Sciences Foundation, and the Jarvis Center. And we will see you on the internet. You can access iGeriCare.ca/events. We'll be putting up a recording or an archive of this video on our Facebook page, on YouTube, and on our events page on iGeriCare. And we'll see you live in a couple of weeks on November 7th. Thank you very much for joining us today.